House Health Policy Committee will come to order. Would clerk please take the attendance?
Chair Rogers.
Here.
Representatives Whitsett. Carter.
Here.
Hadsma.
Here.
Neely.
Here.
Blandville.
Here.
Sophia.
Here.
Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reingans.
Here.
Vanderwall.
Present.
Filler. Mueller.
Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Here.
Madam Chair, you have 17 members present. You do have a quorum.
Thank you. Representative Kafia moves to approve the minutes from our meeting on April 13. Seeing no objection, minutes are approved. We have a little update here in health policy. Every half hour, things change. So if you don't like what's going on, just wait a minute, and it may go your way or not. We were planning on taking up the Filter First packaged House Bills 4340 through 4342 today, but despite a lot of hard work from everyone, bill sponsors, stakeholders, etc., stakeholders have asked for more time to address a couple of provisions that are still potential issues. I hope to bring these bills back before the committee very soon and encourage all interested parties to work with the bill sponsors as quickly as possible to get whatever concerns you have addressed. So, I just want to make sure, hold on one second. We are going to, okay. Next up on the agenda, we will be taking up House Bill 4409 and hearing from Representative Steckloff, then Michigan Association of Health Plans, and Pharma. So first up, Representative Steckloff, thank you for joining us, and begin when you are ready.
Thank you, Chair Rogers and members of the committee. Today I'm introducing a bill that provides transparency for prescription drug prices. This bill will require drug manufacturers to report certain information to the Department of Insurance and Financial Services. If you look on the second page of the bill, during looking at Section 7, this is where you'll see some of this information. So you must submit this report within 30 days if you increase the wholesale acquisition cost of qualified prescription drugs by 15% in a given year or 40% over a 3-year period. As we've seen in the past, studies upon studies have come in that have shown that many of our drug prices have increased about 150% over the last decade. And it's very important to figure out why that is. And transparency has always been an issue we've talked about with drug pricing. So this bill will help address a lot of that. We have more information to provide, and I'm very happy to be joined by our Michigan Health Plans, and they will be going over additional information.
Thank you so much. Do members have specific questions for Representative Steckloff? Otherwise, we will move forward, and I do see Rep. Miller.
So when you look at drug prices across the board, and I see that many other states have done this as well, does this lower the cost of prescription drugs when there is transparency with these other states?
That is the hope. In other states, we've seen where that drug pricing has come from. You know, whether it's from the manufacturers, whether it's from PBMs, this will actually provide transparency on where those increases in prices are coming from. The hope is, with the transparency, to lower the costs. But we don't even know what the costs are because we don't have this information. But that is the goal.
Thank you.
Thank you. Are there any other questions? Otherwise, we will have an opportunity at the end. So thank you, Representative Steckloff.
Thank you.
Next speaking and supporting the bill is Karen Jones from the Michigan Association of Health Plans. Karen, welcome, and begin whenever you are ready. And I see you have a PowerPoint, so we will follow along, and we also have that at our chairs, members.
Thank you, Madam Chair and members of the committee. My name is Karen Jonas. I'm a pharmacist working with the Michigan Association of Health Plans. I appreciate the opportunity to testify today on behalf of 4409. As you can see by some of the slides that I provided, prescription drugs account for a significant number of costs with regards to the healthcare dollar. While the pharmaceutical advances have brought tremendous life-saving medications forward for our patients to use, the rate in which these drug price increases occur threaten the sustainability of healthcare. Currently, right now, prescription drugs account for over 22 cents of every dollar. And you can see that back in 1990, it was less than 6%. So that's a pretty tremendous growth. It's the fastest driving piece of the healthcare costs for the dollar-wise. Spending on drugs is continuing to go up. By 2025, you'll see almost $615 trillion will be spent on prescription drugs. It's a significant comparison price increase compared to other sectors in the healthcare arena. About 80% of Michiganders support legislation that would require transparency. That's a pretty significant number of individuals. It also closely represents the number of Americans across the country that also do. Kaiser did a poll a couple years ago that was 79%, so we're comparable with the rest of the country with wanting to know about prescription drug price increases. The problem with high-cost drugs, if you bring it down to the clinical level, is that about 30% of Americans are not taking their prescriptions correctly. And a lot of them contribute that to the high cost of the drugs. On the negative side of that, of course, you've got suboptimal clinical outcomes for patients, and then it results in higher increases of healthcare costs by pushing the patient to the hospital or additional physician visits when they no longer are taking their prescription drugs appropriately. So that's a concern. Further compounding is the fact that the cost of prescription drug increases are far outpacing the consumer price index or the inflation rate. It's about 150% higher than the price inflation rate over the last decade. Kind of coming to your comment earlier, Representative Miller, Vermont was the first state to pass prescription drug price transparency in 2016. And we've seen kind of a steadying, flattening out of drug price increases and a slight lowering since that transparency has been present. So we believe it's working. Skyrocketing price increases impact just about every drug that's out there, from EpiPen for life-saving allergic reactions to naloxone for opioid overdose treatment. Every price increase is a sticker shock to Michiganders, and it's not at the rate that we've seen before. When I was a younger pharmacist, and I'll tell you that was many years ago, we had a few people that would talk about, I have trouble affording my prescription drugs. That number of individuals that mention that is much higher now because these prices not only are increasing for existing drugs, it's the current new drugs that come to market at much higher list prices as well. That's also alarming. Prescription drug transparency does matter, particularly when you're looking at a lot of these new treatments that are coming out at $1 million price tag. I don't know about you, but there's very few budgets that can afford some of these new drugs that are out there. They're great, they're life-saving, but at some point we've got to address why the costs are so high. Now, typically, the drug industry has mentioned that competitive forces in the marketplace will normalize pricing over time. However, that's not the case. When we see generic drugs that have been out for decades, their prices continuing to go out. So that doesn't really correlate with that theory. As well as out-of-pocket costs for patients, what you can see here is their prices have pretty much stabilized. The health plans and employer groups have done a great job trying to keep costs as affordable as they can for consumers. But you'll see by the curve going upwards, it's the employers and the insurers or the payers, the government payers, Medicaid and Medicare, that are bearing the brunt of these high price cost drug increases. Now, the Centers for Medicare and Medicaid Services, they're the government payer for the two largest healthcare programs, Medicaid and Medicare, which pretty much about 60% of Michiganders are under those two programs. They've made transparency pretty much a priority in every sector of the healthcare market. Prior to the recent presidential edict that prescription drugs were going to be under purview of the government negotiations, transparency only occurred in other sectors of the healthcare market. Unfortunately, the Medicare price negotiations didn't go far enough. We've seen insulin, the prices come down, the list prices, and that's a big boon, but it also highlights the fact that the drug was severely elevated in prices over a decade. It was almost about 600% higher than, 10 years previously. So, yeah, you can raise the price up and lower it. It's really not a sale if you still have trouble affording the prescription drugs. And unfortunately, the notice last week, HHS noticed that the prescription drug rebates on the federal side is only for 20 drugs. And those are the high-cost biologic drugs that are really not for the everyday American. They're for those individuals with chronic severe diseases. So it's not going to really impact to the level that we hope it's going to. So prescription drug transparency, it does matter. It's not anything new. The European Union has been having price transparency for a long time, and that's 33 European countries. So the U.S. is considerably behind in that arena. Our prices in the U.S., unfortunately, are higher than a lot of these countries, and part of that is for that reason. As I mentioned before, Vermont is the first state that passed prescription drug transparency in 2016. A lot of these states, those reports are available publicly on their website. You can get some great information. Since then, there's a total of 19 states now that have drug price transparency, and as I've mentioned, the prices have flatlined or they've come down slightly. And as you can see, Vermont had a 79% decrease in the amount of drugs that qualified for reporting, and Oregon 70%. Those are significant numbers, which means those prices that hit the threshold for reporting, the prices have not gone up to that extent. So we believe transparency and the public pressure that's out there is tremendously working to keep prices affordable for individuals across the country. So with that said, Michigan Association of Health Plans, we support the legislation. However, we're working with the bill sponsor. We believe the levels of threshold reporting in Michigan are still too high. We would like to see those thresholds lower. That would strengthen the bill and provide even more prescription drug affordability for those of us in Michigan. So with that, I want to thank the committee members for allowing me the opportunity to testify. Madam Chair, I'd be happy to answer any questions if anybody has them.
Thank you. Representative Reinkens, you're good? Representative Hadsma.
Thank you, Chair Rogers. Ms. Jonas, I have a question about variability of price in context of which pharmacy it is where the medication is prescribed and filled, and also what part of the state, if those are additional variables where this prescription is being filled.
Yeah, that's a great question, and those variables will occur. Like any other product that's purchased, a lot varies upon the volume of the purchase. So if you've got a large chain that's purchasing as a whole, they're going to receive a better price than maybe an individual pharmacy that may be purchasing on their own or through a buying group discount. So yeah, you will see variabilities across the board, be it whatever it is, whether it's a specialty pharmacy, a health system pharmacy, or a retail pharmacy. Yeah.
And in terms of areas of the state, I recall some years ago being told about how differently priced MRI studies were in different parts of the state, including very proximal parts to each other.
Yeah.
What about that in relation to getting a script filled in Iron Mountain compared to, say, Kalamazoo?
Yeah, you'll see that as a UPer myself from Ironwood. You know, everything was always more expensive in the UP. I mean, transportation costs to get the products there, especially now with, gas prices and everything else, the trucking industry, shortages everywhere. You'll see those variabilities across the board, unfortunately.
Thank you.
Representative Roth.
Yeah, maybe, thank you, Madam Chair. Let's start there. I certainly was one of those that went after some of the PBMs, pharmaceutical things last term. Wasn't opposed to that. Tell me what kind of transparency you're asking for the pharmaceuticals to provide. What's this investigation, if you will, or reporting going to look like?
Right, that's a great question. So it has varied across the country, state by state, on what's required. Typically, what's required is any drug that caps at the threshold for a price increase, They're required to provide notice to the state, and that varies upon how a bill is written. I mean, here it's on the price increase. Some other states have done in advance of a price increase, they've required notification. The reasoning is why the price increase is there. Some states have required R&D. This bill is not addressing that at this point. So it allows a public arena for a discussion about where those prices are increasing. And as the state is a large purchaser of prescription drugs through the Medicaid program, and every year there's appropriation bills that are dealing with costs attributed to prescription drugs, having that information available about what those price increases are, I think is very valuable for you all as well as other policymakers.
Thank you. Do you see the legislature being involved with that, or rulemaking maybe from department?
I think it could be either or both. And coming to your comment of the pharmacy benefit manager, there's going to be a price increase through the entire drug distribution system, whether you're the pharmaceutical manufacturer, the wholesaler, the PBM, the pharmacy. But at the end of the day, the drug manufacturer sets the list price. It starts there. So requiring that transparency on the manufacturer side sure opens the door to assess the rest of the spectrum of distribution.
Thank you, Madam Chair.
Minority Vice Chair Vanderwall.
Thank you, Madam Chair. Appreciate it. Thank you very much. And these questions may need to be directed also to the bill sponsor. But as I read through the bills, the reporting, there's a reporting mechanism. If they fail to report, it's a $100,000 fine.
Yeah.
I guess what I'm trying to ask is, who's gonna review these reports that are sent in? What is it gonna cost the state to employ these folks? And then what is the true outcome that we're trying to follow? If the reporting is harder than it should be, or it is too strict, what are we really going to get out of it if we don't have enough people to impose? So I guess the question is, how much is it going to cost, and how many people are we going to have employed, and what are the real benefit if we can't get that data?
Representative Steckloff, if you'd like to address that.
Thank you, Vice Chair Vanderwall. It shouldn't provide any additional manpower. The reporting is done just at the financial services. Now, once we get that reporting, the way I personally see the bill, and that was a question that Representative Roth did, this is where the legislature can come in and kind of look at what is needed. So I wouldn't worry about the additional costs for manpower. That's not what this bill addresses. The bill addresses just going in the reporting product. I don't know if I answered your question.
Well, yeah, you did. I guess it gets down to, we've done a lot of bills over the years, and just about any time you affect any department and you want reporting, they're going to ask for, when you've talked with DIFS or Laura on this, what has been their advice, or have they been basically very neutral right now?
And I think we don't have the House fiscal analysis back yet, so that may answer. Oh, we do? Okay. I will let Rep. Steckloff address that, but also there is a House fiscal newly up. So, but Rep. Steckloff, if you want to.
Yeah, so in the legislative analysis, I believe that is in here. I just got this today as well, but this bill has been introduced numerous years, and every year we have seen that they have said it shouldn't really do too much. And as you can see from here, as I'm reading it pretty quickly, I forgot the second question you asked. I apologize.
It's just basically if you have had conversation with the department.
They're neutral.
Thank you. Representative Glanville.
Thank you, Madam Chair. I just wanted to go back a little bit to the cost of drugs on your average person. And I know there was some data in here related to comparing the out-of-pocket costs to inflation in general. But I was wondering if you have data that breaks it down, like maybe a little bit more to compare it against other everyday costs. So how do prescription drugs line up against the cost of food, gas, those types of things. Certainly that comes into play when people weigh those decisions in regards to what you mentioned and why people do or don't take their medication as prescribed?
Yeah, that's a great question, and we do have some statistics. If you look at overall, if you average all the drugs across the board, so you're looking at generics and brands and biologics and vaccines and all that together, you're about a 20% cost for average individual for prescription drugs. Rent prices, obviously with the pandemic, we know that the rent prices went up. They're about 6.5%. Utilities are about 2.8% for an individual. Michigan's lower than some other states with regards to that. Food is about 3.2%. Obviously, that's higher now than what it was pre-pandemic. Wages, about 3.5%. So, we've got some. We can provide additional details as far as if you want the more formal breakdown. We've got that information. We can follow back up with you on that. But the healthcare sector continues to be a large driver of costs.
Thank you.
Thank you. Representative Fitzgerald.
Thank you, Madam Chair. I just wanted to clarify in this, though, that there is no prohibition on increasing the price beyond that 15 or 40%, these margins listed. It's just that there has to be that explanation to the market and to the consumer to, again, bring forward a little bit more of that consumer education piece of this.
That's correct, although I would hope prescription prices don't keep going up at that percentage. It's unsustainable, but you're correct. There's nothing that prohibits those increases from occurring.
Representative Farhat.
Thank you so much for your testimony earlier. I was just curious if for the most current year or most recent year's data, you have any relevant information for how much we've seen prescription drugs cost just year over year. We know last year inflation was a little higher than usual, but how much did prescription drug prices, based on the data you have, outpace inflation, right? So when we hear that inflation is the argument, how much did it outpace us? I'm wondering if you have any data relevant to that.
I do. I can follow back up with the committee members with regards to that, and absolutely. And if you're looking at a drug-by-drug breakdown, I'm kind of a research geek. I mean, those individuals that know me know that. I've got it broken down by Medicare and Medicaid program by drug even, if you want that too.
Yeah,
So if you want deep dive, I can help you out with that. If you want general, I can help you out with that too.
I just think topographically, just looking at the industry and then looking at drug prices versus what we see inflation being and seeing how fast drug prices are or are not outpacing that is going to be really helpful, especially for when we ask for transparency in the market, right? If we're seeing inflation being 8% last year, but then we're seeing drug prices being double, triple that,
Yeah.
right? Then it begs the question, why?
Yep.
So to that point. So I was
Sure
just
thing.
curious about that number.
Yep.
Thank you.
If you can send that to the chair, and then we can get that out to members. Thank you. And I think part of the answer is it depends. Like you said, it's drug by drug.
Yeah.
Thank you. And then we have one last question, and we'll move along. Representative Van Workum.
Thank you, Madam Chair. I guess may have two different questions here. You've mentioned that other states have this in place. How different do you see the prices between those states? Whether there's significant change between those states or not? And then you had mentioned that some states have the R&D component in it, others don't. From my analysis that I'm seeing here is that we do have the analysis in here. Why is that part necessary, and what do you have to protect the intellectual property that is put in there moving forward?
So I can answer maybe part of that question. Maybe I'll save the protection for pharma when they testify, but we're not asking them to divulge trade secrets. I mean, when a pharmaceutical manufacturer, manufactures a drug, and then a generic comes out, they have to provide basically their formula to the generic manufacturer to make. So if you want to talk about concerns about intellectual property right, the system is set up already for that sharing capability. So we're not really asking them to violate
It's not
property.
necessarily that, but it's also how much money they've done to develop it and what it's not just the actual formula, but it's also their process and where they seek to make market and that. So I guess how often is that R&D, and why is that so necessary as a component of this legislation?
Well, some of it comes down to concerns with the fast merging of some of these pharmaceutical manufacturers. You see a lot of that now where somebody develops a product and then it's sold off to another manufacturer and then the product price is increased, and is that really R&D or is it marketing? So some of the concerns and why that becomes relevant is the cost of the drugs. R&D is truly not as high as, the pharmaceutical industry wants you to believe.
Thank you, Karen. I think we're going to have Pharma talk about
Yeah.
that piece. We've got one
Yeah.
last question from Rep. Cuffia, and then we're going to move along to allow Pharma to testify as well.
Thank you, Madam Chair, and thank you for your testimony, and Rep. Steckloff for the bill. So I was curious along the lines of having this report annually go to DIFS. Might it be appropriate for us as the Health Policy Committee to bring that up before our committee just to review the pricing and how it might be impacting our constituents? I'm new to this committee, but it seems to me that that might be a valuable use of such a report, just so that we are able to kind of keep an eye on how that is impacting our constituents, because I certainly have personally, and my family and many of my constituents, been impacted by skyrocketing prescription drug prices. So it's certainly of interest to us in representing our constituents.
Thank you, Representative Cuffia. Just for your information, whenever these reports are required in state statute, they are publicly available to everyone, not only the legislature, but members of the public, and we can make sure that that report gets to the members of Health Policy. All right. Thank you so much, Karen.
Thank you.
Next up, we have Shauna Gardner, Director of State Policy from Pharmaceutical Research and Manufacturers of America, wishing to speak, and I believe she's on Zoom. Welcome.
Hi, thanks so much. Can you all hear me okay?
Yes, we can.
Great. Madam Chair, members of the committee, good morning. Thank you for letting me zoom in virtually here. I've been traveling, and actually now I have a cold, so I'm saving you from whatever these sniffles are. So once again, appreciate you letting me zoom in today. I'm Director of State Policy for the Pharmaceutical Research and Manufacturers of America, or PhRMA. And as we have heard in this conversation already, I do think we can all agree patients should never have to go without their medicines or struggle to afford them. And we do want to work with this committee in the state of Michigan to ensure patients get access to the treatment they need at a cost they can afford. However, PhRMA opposes 4409 because it really isn't not the solution to ensure patient access to their medicines. So before I discuss our specific concerns related to 4409, let me just put cost into context, because it's very important to address the faulty assumption, which we've heard already here today, that drug spend is the major driver of increases in healthcare costs, especially when health insurance and plan administration costs are rising at more than twice the rate of drug spend. So when we look at drug costs, we need to take into consideration the net price for brand medicines versus the list price, which once again, we've been hearing about already today, which takes into account the billions of dollars in rebates manufacturers pay to the plan or PBM to have our drug on the formulary. When we do look at net price for brand medicines, they only increased 1% in 2021, which is below the rate of inflation for the 5th year in a row. And as we look ahead, net price growth, net price, is projected to be 0 to 3% per year through 2026. What's not working are the misaligned incentives in the current supply chain. 3 PBMs control 80% of patients' medicines, and they use their market power to get tens of billions in rebates and discounts on medicines from manufacturers, $236 billion in 2021 alone. That savings should be going to the patient. This can't be ignored and must be taken into consideration when we're looking at affordability and to understand the factors that are influencing the cost that patients are incurring at the pharmacy counter. It's also important to note more than half of every dollar spent on brand medicines went to payers, middlemen, providers, other stakeholders in the supply chain. So now to our concerns. I want to be brief here because I can imagine there's some questions, but this legislation is going to ultimately result in unnecessary reporting and repetitive reporting, things we already report out on our 10Ks, of prescription drug price information. But most importantly, it doesn't help the patient. It doesn't help them understand their cost-sharing responsibilities, which is set by the insurer, or whether they might be paying more for their medicine than their insurer. Oftentimes, a patient can actually pay cash, and it's cheaper at the pharmacy counter than what their insurance is covering. So while well intended, this bill does nothing to actually lower the cost of prescription medicines for the patient. It ignores the reality that health insurers not manufacturers, despite what was heard today, determine the price a patient pays out of pocket for a prescription medicine. And then further, this bill mandates that companies disclose proprietary and confidential information that would not benefit the patient or decrease healthcare costs, and if anything, could confuse the patient. Our industry is one of the most heavily regulated industries in the United States, and we already report extensive information on cost, sales, clinical trials, R&D, and more. So if it's the intent of this committee to help patients afford their meds, Pharma suggests two policy alternatives that would immediately lower the cost of prescription medicines. And this plays into a member, I actually forget who specifically it was, specifically asked, if we do all this reporting, what is this going to cost the state, and what's it actually doing for the patient? It's not going to do anything for the patient, but this will. We should pass on rebates, the rebates and discounts that manufacturers provide to the plans and PBMs to the patient. And if we do so, it's reported that approximately $800 per patient in out-of-pocket costs annually will be discounted to the patient, while also only increasing premiums about 1% or less, despite what the plans will tell you. So we should be passing on those discounts to the patient so they can immediately feel the benefit at the pharmacy counter. We also should require plans to offer options with a fixed dollar drug copay or no deductible coinsurance, in addition to the other plans they offer. So a patient that has a high cost drug potentially will not feel that out-of-pocket cost at the pharmacy counter. I'm very passionate about this issue, as you can tell. But in closing, I appreciate the opportunity to testify today. I just respectfully ask members of this committee to oppose 4409, which once again, we want to look at how do we actually lower the cost for patients? And this is not going to do it. And it could actually misinform the patient about the price they pay. So we welcome the opportunity to partner with you. We want to continue this conversation. I know my colleague Peter Fotos is in the room with you. And we want to continue this conversation. There's things we can do to get at the cost of drugs, but this is just an exercise that's not going to get us anywhere. So once again, thank you. I welcome any questions, and we'll open it up.
Thank you so much, Shauna. Did you want to touch on what Representative Van Workum's question was, and he can repeat it if you need to have him repeat it?
Yeah, if you can repeat it, that'd be great.
The R&D piece.
Well, put me on the spot, Madam Chair. Just a question about, I think it was two parts, but particularly on the R&D portion of it and the reporting that is necessary, whether that's a necessary component of legislation. And then the second one was there are other states that have this in place. Do you see a cost difference between those states? But I think the one the chair was referring to was on the R&D portion side.
Yeah, from an R&D perspective, I mean, in regards to specific processes of what our companies are doing and the investment being made, there's a lot of information that's already out there as to what our companies are doing. So there's some aspects of the reporting that's a repetitive exercise for our companies, but also just generally, there's also some information that is proprietary and confidential and should not be reported in this way. We already report out a lot in our 10Ks. So there is, once again, we are a highly regulated industry. So there is a point of this there's a repetitive aspect, but also just there is proprietary and confidential information that should not be reported out.
Thank you. Representative Conlon.
Thank you, Madam Chair, and thank you, Representative Steckloff, for bringing this to us. And yes, thanks for your testimony today. I guess I have a question. If you're saying that the net price increase is so small, it's only 1%, and that the problem really comes from this list price and the PBMs and all of the supply chain, why wouldn't you welcome this kind of reporting to actually show that and to show that, in fact, you are not the problem here? It feels like this would be a benefit to the criticisms that are coming at you. And also, I do see in this bill that it does say that this would not that the information you would have to give would not be anything that would give up proprietary harm to a drug manufacturer. I mean, it says that here.
Well, I'll start with the reporting of list price. I think the concern is there's a level of information that's already out there, but I think what we really need to focus on is how do we inform the patient of what they're actually going to be paying? And I think whether it's even some of the hospital transparency that's gone through on pricing, it actually can really confuse the patient, because we really need to look at what the patient is paying, which is set actually by the insurer. So just focusing on list price and not taking into account the also immense billions of dollars in discounts that the manufacturer is paying in, it doesn't give the right picture and the accurate picture of what drug costs are actually, not only for the patient, but also just in actuality, what the discounts paid by the manufacturer going towards the plan's PBMs, what the plan PBM is actually paying for the drug. So there's that discrepancy. And so I think that's why when we look at actual real reform in this space, you need to take into account and take into consideration all the stakeholders that are involved in order to have real reform. I mean, don't get me wrong, transparency is transparency. I think it's important across the board for all stakeholders. But there's a point where it might just be an exercise of reporting and not actually moving the needle in the right direction.
Thank you. Seeing no, Representative Hadsma squeaked in.
So how do we, in response to your set of two recommendations in context of the first, pass on the rebates that pharma gives to the PBMs to the patient? How's that accomplished?
Yeah, so actually West Virginia was the first state to just about 2 years ago now to pass a bill called Share the Savings, which shares the rebates and discounts from the manufacturer pays to the PBM at the pharmacy counter to the patient. So it's required. So it was the first state to do so, and we're seeing states follow in this last session as well. So there's legislation out there, and I know actually once again I'll defer to my colleague Peter Fotis in the room to grab you after the hearing to be able to talk further with you. But we do have legislative language we're happy to have you take a look at, which really will get at the misaligned incentives in the system, these discounts that are being paid, and ensuring the patients actually benefiting from the discount that our manufacturers are paying.
But from the perspective of the patient's rights, we could certainly do something like share the savings legislation and also do something like this legislation to maximize savings to the patient. Am I correct?
Yeah, definitely. We would love to partner with you on that.
All right, last question, and then we'll move along. Minority Vice Chair Vanderwall.
Thank you, Madam Chair, and thank you for being here today. Of course, this is always, as you see, well, you don't see, you're not here, but a full room. But the question, it really follows up with the representative that was just talking, is, the rebates technically right now go back to the state, which goes back to the patient. But ultimately, I think going to Representative Van Werkum's earlier question when it comes to R&D, part of that is that right now we don't share that R&D cost to other countries that buy those prescription drugs. Is that correct?
Can you repeat that again specifically? Sorry, I'm not following you
Yeah,
exactly.
well, the rebates, I believe that you said that you guys would already be involved with that, but rebates that are coming back to the state right now are already being reflected to the patient. I just don't think that because of the way things work, they actually see that, and we're not very clear, and it's complicated. But the other part of it is when it comes to drug pricing and what prescriptions are, when we develop drugs, right now we are, from what I understand and what I've learned, we're not really passing a lot of that R&D on to other countries or other people that buy those drugs from you, or sharing that. Is that correct?
That's challenging. I will say in how to answer that question. There's price controls in other countries that are setting the cost of the drug. So in regards to the industry in this country, we're spending billions and billions of dollars in R&D. And I would say that, we're not necessarily, other countries, when you say, are not shouldering the cost of that R&D. Our countries, many of our member companies are based around the world as well. So they have headquarters in other countries. So I guess the question you're asking is other countries necessarily not footing the bill of all the R&D? Is that kind of what you're saying? Is it?
Yeah, that's exactly what I'm asking, is that if other countries aren't paying their fair share of the billions of dollars in development, that leaves our consumer to foot that bill here in the United States. And my question is, if that's the company direction, how do we change that?
Well, then I'm also going to tell you that when you're in other countries, you also don't have access to the drugs that we have in this country. So, it's a much larger conversation than just saying that our country and our consumers and our patients are footing the bill, because in many of those countries, you actually don't have access to nearly the number of drugs in as quick of a time frame as you do in this country. So, that it definitely warrants a much larger conversation that we can have with you. But it's also not the full picture by just saying that that other countries aren't necessarily chipping in the way that we are.
Thank you so much for your testimony. I do want to quickly acknowledge, I think they just had to leave, but some of the emergency room physicians, part of the healthcare team, were in the room joining us. So thank you for being here. Next up, we will have testimony on House Bills 4362, 4363, and 4364. I'm going to give the whole lineup so you know who we can have questions for. So bear with me while I just kind of give the lineup of who will be testifying. Representative Brabeck and Representative Price. Patrick Wells O'Brien, Vice President of Communications and External Relations with Gift of Life, Michigan. Armand Baskin, a resident of Flint who is on the waiting list for an organ donation. Jeff Guilfoyle from the Michigan Department of Treasury, and Aaron Shore from the Michigan Department of State. So would Representative Brabeck and Price come forward and testify on your bills? You can come up too, Patrick, all three of you, that's fine. That's fine.
Thank you, Chair Rogers. Committee members, we appreciate being able to be here before you to testify on these bills. What these bills do is they allow Michiganders to join the state organ donor registry by indicating that willingness on the state income tax form. So Rep. Price is here with me. Rep. Neely joins us on this package, and we are very grateful to be partnering with Gift of Life and the Department of Treasury and the Department of State, who are also here, as the chair mentioned. So here's some background on these bills. Most of you are familiar. If you look on your driver's license and you are an organ donor, you have a little heart on the corner. I was going to pull mine out to remind us all, but I'm sure a lot of us already have that here. So when you go to the Secretary of State's office right now to renew your state ID or your driver's license, the clerk will ask you, would you like to become an organ donor? And you will get that heart insignia there on your license. Well, this has substantially helped the state organ donor registry over the past few decades. The past 3 years really have a different story to tell. So during the pandemic, as many of us are aware, the Secretary of State had to necessarily stop taking many in-person appointments. And that caused nearly all driver's license and state ID renewals to take place online. Again, as we understand, because of the pandemic. Unfortunately, this unintentionally impacted the organ donor registry, which is currently growing at the slowest pace since its creation. So while Michiganders can absolutely add their name to the state organ donor registry online, the question, though, of whether or not to do so can often be skipped when we're just kind of going through our renewal. That one can be skipped. So what our bill package would do would be to ask this question on our state income tax form to give Michiganders another opportunity to be able to add their name to the registry. And so with this question being added to our tax forms, which I hope that many of us fill out more diligently than we may an online renewal, it reduces then the likelihood of Michiganders skipping over that question and could grow the organ donor registry faster than ever. So once a taxpayer makes this decision to join the registry in this way, they'll answer some questions on a separate donor registry question to be filled out on their annual returns. It includes basic info, social security number, driver's license, state ID number. And then for joint returns, it would need to be indicated for two separate folks. So the donor schedule would then be sent to our Department of State to be added to the state-maintained organ donor registry. So one of the things that we keep in mind when working on these kinds of bills is we have over 2,400 Michiganders who are on the list right now to receive an organ right now. And being able to increase our list, which right now I think we have 54% of Michiganders are 56%. 56% of Michiganders are a part, but some states are at 70%. And we need to be able to increase the pool of folks to be able to get that 2,400 number much lower. So this is life-saving legislation, and it's a issue we need to tackle from multiple directions, but this is just one of the avenues that we can use. And I'm grateful, and we are grateful to the chair for allowing us to be here, and we hope that you all will consider supporting this life-saving legislation.
Thank you. Representative Price?
Yes, thank you, Chair Rogers. My bill in this package is a small but important piece. It keeps the information that is shared secure so that Michiganders can be confident that their information is safe and secure and that they'll participate in this process. Thank you.
Thank you. And I have my handy dandy heart on my license right here. So if you don't have that, members of Health Policy, I encourage you to join me.
I'll match you. I've got it too.
Wonderful, Thank you, Vice Chair Vanderwall. That's awesome. Patrick, if you would like to testify, begin when you're ready.
Thank you, Chair Rogers and committee members. Gift of Life Michigan is the federally designated organ procurement organization for our state. We are 52 years old, and we are the second oldest organ procurement organization in the country. Our relationship with the Secretary of State has been a strong one. 95% of the 56% that Rep. Brayback mentioned of Michiganders on the list came because of the relationship with Michigan's Secretary of State. And people of the state of Michigan felt that this was so important that that's the thing that is on our driver's license. And in addition to the shift to there being fewer opportunities in person to have the registry question presented, the law changed so that instead of going in to have your picture taken every 8 years, it's now every 12 years. I love that as a driver, but that really meant that the question was presented a third fewer times. And this has really had a negative unintended consequence to Michigan, organ donor registry. One organ donor can save up to 8 people's lives. And in the audience is Rachel, and she will tell you she was experiencing heart failure. And there's no therapy, there's no other medical solution. If there was not a heart available, Rachel wouldn't be here today. And so that's how important this is. It isn't big numbers, but to the people whose lives are impacted, it's a very big deal. And so one yes makes a big difference. And what ends up happening is when our team goes in on someone's worst day, their loved one has experienced a brain death or some form of death that is consistent with donation being possible, and Gift of Life Michigan shows up to present this opportunity for that loved one to have a life-saving legacy. Even though 9 out of 10 Americans will repeatedly say we're for organ and tissue donation, only a third of the time in that moment of trauma will that family say yes. 2/3 of the time, because of timing, grief, what all the reasons, they don't say yes. So we want to make sure that those 9 out of 10 generous Michiganders who believe that this is a good thing have more opportunities to make that wish known. And this legislation presents that question every year when you fill out your taxes. And it will save lives. And we thank you for considering this important act.
Are there questions at this point? Representative Miller.
This is such an important topic. I have a lot of people who are older who think that their organs have an expiration date. I'm too old to give.
It's a great question. So there is no upper age limit. We sort of say age 75, but we recently had someone who donated a liver in their 80s. And tissue donation really has no upper age limit. We had a tissue donor who was 101 last year, and the 80-year-old son said, "Are you sure she's over 100?" But yes, it's absolutely, there is no upper age limit. Thank you, Rep. Miller, for asking that question.
Thank you.
You're not
No
too old.
expiration on body parts.
No, there is not.
Representative Glanville.
Thank you so much for being here and for bringing this forward. I think this sounds like a fantastic solution to the challenges you've presented. I did want to clarify, however, is this something that you would need to renew annually? Do I need to?
It
or
is
it a one
not.
and
It's
done?
just like when you become a voter. Once you're registered, you're registered. So if you are already registered through the Secretary of State and you add this, you check the box on your income tax form, it's no harm. It's absolutely not a problem. The registration is already recorded. And once it's there, you will get a heart on your license. Next time your license is renewed, the Michigan Department of State has a practice of sending a heart sticker out with new registrations between driver's license renewals, and that will allow people to know that you're registered as a donor. And once you're registered, the Secretary of State doesn't ask the question again, and you're registered.
All right, and thank you. I had a follow-up question about how you would then designate it. So if I choose on my state income tax form to be a donor, and I don't renew my license for 7 years, it won't appear on my license for 7 years?
You would get a little sticker. But
okay.
what's most important, the heart is important on your driver's license, but what we really look at is the Secretary of State's database. They have the definitive database that our team looks at to see if someone is registered, and that's what really counts. That's what we're looking for.
All right, thank you so much.
Yeah.
Would you characterize it as one and done?
One and done is a great characterization.
You can steal that.
Chair Roberts. Thank you, I will. Yes.
I do see we have a couple other questions, but I do want to give, we have a person that is on the wait list for an organ donation waiting patiently on Zoom. So I would like to give Armand Baskin an opportunity, and then we'll come back to questions. Armand, are you with us? We cannot hear you yet. You're muted.
Can you hear me now?
Yes, we can. Welcome.
Okay. Good morning / afternoon. And just so you all know, there go my heart.
Beautiful.
Thank you for having me. My name is Armand Baskin. I'm 41 years old. It'll be 4 years, July the 8th, that I've been on dialysis. And before I got sick, I really didn't know much. I wasn't really well educated about the donation process and different things like that. Growing up in the inner city, we were taught differently. We were taught that, you donate, if you die, you won't get anything, or if, somebody else dies and needs something, they're going to kill you. Just different myths that you really don't understand. It wasn't until I got sick in 2019, and really took this thing serious, and it was like a life or death thing, because I really didn't want to get on dialysis. I heard of it, I really didn't know about it, but once the doctors explained the severity of my sickness and my illness, I really didn't have a choice. And like I said, when I initially started dialysis, I didn't know anything. I got with Gift of Life, and one of my good friends, Shalonda Jones, she's actually works for Gift of Life, and I volunteer all the time. I go to different schools and talk to these kids about how important it is to stay up on your health, because I didn't know 20 years of untreated high blood pressure, it almost took me out. But by the grace of God, my wife got me to the hospital in time, and I was able to get on the dialysis, and I'm thankful for that. But my quality of life stinks. I'm dependent on a machine. It's terrible. Donation is the best thing that you can do. If you look at me in the streets, you wouldn't guess. I'll give you $1 million that anything was wrong with me. And that's why I'm really pushing that sickness doesn't have a look. You can't think that everybody that has something going on, you can tell. You really can't. So this is very important and near and dear to my heart, because even if I don't get a donation, if my kids carry any of the traits that I have, for this kidney disease, hopefully they will get a transplant, or anybody else. So I'm glad you guys, allowed me to testify. but please, man, we need this for people like me. You know, it means a lot. So again, thank you, for your time, and let's get this thing rolling, please.
Thank you so much, Armand. If you can stay on the screen, I'm going to pause and just have people raise your hand if you have a question for Armand. If you don't have a question for him, we'll come back to you in a second. But does anyone have a question specifically for Armand? Well, I would just like to say thank you again so much for testifying. Your story is really impactful and powerful. I myself am a physical therapist and have worked with some folks on both sides on the wait list as well as recipients, and I really appreciate your story. Thank you so much today.
Thank you for having me.
All right, we're going to return to questions. I think I had Rep. Conlon next.
Yes, thank you for your testimony today. Thank you, Madam Chair. I'm just wondering if you have ticked it on your license for now, or you have done in the future, hopefully on your tax return. Are you still, should you talk to your family about it? Is there in other words, if I have ticked it and something happens to me, can my family stop me from being an organ donor?
Thank you, Rep. Conlon. That's an excellent question. This is one of the wonderful things, and we take this as a sacred duty on our part. When you check that box, that's considered first-person authorization, and it is legally binding, and we honor that. And we work with families every day to explain their loved one's selfless gift. And the family cannot override that. The exception to that is when teenagers go in and get their driver's license and they check the box and they get the heart on their license. A parent can override up until age 18, but that never happens. Parents are so moved by the generosity of their loved ones in that moment of grief that we've never had an instance where that's happened. Thank you.
I'll come back to Rep. Miller just because I want to get to first questions. Representative Schmaltz.
Yes, thank you for testifying. I think this is a great idea. I was just curious, and excuse me if you answer this, do any other states, have they done this? And do you know what happened? I mean, did it increase these donations?
That's a great question. Michigan would be the first, and so there's a lot of enthusiasm with OPOs across the country, like Gift of Life Michigan, looking to Michigan to finally do this. I go to a conference of my colleagues, and they say, if we could do this in our state legislature, because Michigan is not alone. All of the DMVs in states across America are reducing the number of transactions, moving more transactions online, despite their unequivocal support of donation. And so we're not alone in facing the declines in the registry. And so our legislative priorities are to create more education and more opportunities for the question to be presented to citizens. And if Michigan does this, it'll be the first.
Well, that'll be interesting to see what happens.
Great question, Representative Schmaltz. And I, for one, am tired of being number 41, 42, 43. So I am very competitive, and I like our odds. Representative Hadsma.
Thank you. This is a question for Representative Raybeck. And it's because I want to make sure my notes are consistent with your numbers. So how many would-be recipients like Mr. Baskin are awaiting organ donation? You gave us the number, and I don't know if I have it accurately, in Michigan.
I can answer for the representative, if that's all right. So there's 2,400 Michigan adults right now on the waiting list.
I want to make sure I wasn't off by
Yeah,
a few thousand.
and most of those are like Mr. Baskin, who are waiting for a kidney. And it's a disproportionate amount of people who are people of color. About 30% of people on the waiting list are people of color. Additionally, there's 16,000 people lingering on dialysis. Many of them would benefit, and they aren't even on the waiting list. Plus, there are people who are too sick to be on the waiting list, who didn't get registered and added to the registry or the waiting list, because you have to be a patient of a transplant center. Michigan has 8 transplant centers, and they're all in the lower, more populated part of our state. And so that's a burden for some people to get that diagnosis if they live in more rural areas, if they don't have access to health care. They might not ever be listed. They may not ever be on dialysis. And so we do believe the number is much greater than those.
16,000 on dialysis.
In Michigan.
I got that right this time.
Yeah.
Thank you.
Thank you so much. So I think next we will bring up Aaron Shore from Michigan Department of State and Jeff Guilfoyle from Michigan Department of Treasury if you both want to come up. Thank you.
Well, thank you. I'll go first if I can because I think Treasury maybe has more details. This is a newer process for them. So I'm Erin Shore. I'm the Legislative Policy Director with the Michigan Department of State. I apologize, I did not bring any heart stickers with me today. I can't sign you up, but check your heart is the phrase that we're using, and I can certainly get you the information to go to our website if you do need to sign yourself up. The Michigan Department of State is very proud of the relationship that we have with Gift of Life and with the Organ and Tissue Donor Registry. As Patrick said, 95% of those registrants have come in through the Department of State across multiple secretaries. It's not a partisan relationship at all. And while we know everyone appreciates the ability to conduct transactions online and by mail, we have been dismayed by the trends that we're seeing. When Gift of Life first came to the department with the idea of collecting data through other partners, we really had to stop and think about that for a minute because it is such a sacred responsibility. It's a legally binding decision, and so we want to make sure we're getting that information right and that we can trust the quality of the data the Department of State is receiving. But we thought, who better to partner with as our first test case than another state agency that's already used to handling very sensitive data and protecting that just as we need to. So we were excited to enter into this conversation with the Department of Treasury and looking forward to this potential partnership and are happy to support the bills today.
My name is Amanda West. Thank you, Chairwoman and members of the committee. I'm the Legislative Director for the Department of Treasury, and with me today is the Chief Deputy Treasurer, Jeff Guilfoyle, to talk a little bit more about our support of the bills.
Thank you, and thank you, members of the committee, for having us here today. I'm just going to talk real briefly about how this is going to work mechanically and note that we're really pleased to support these bills. So we're going to add a checkoff to an existing form on the income tax bill where you already can make charitable donations on your tax form. You'll check that. We'll provide the information to the Secretary of State on a regular basis. They can take it from there because they have all that experience with it. Keep in mind that when taxpayers sign their tax form that they're attesting that everything contained in the tax return is true and accurate. So taxpayers will get the indication by signing the form that they're sincere in their contribution. I'll admit, as noted, we would be the first state to do this. So we really don't have a good feel for how many people would actually take us up on this. But I will note the cost of this is exceptionally low. So we're already collecting the data. We already have the existing tax form. We're just adding it to the form. So we can do this at very minimal cost and send it over there. And this really does have the opportunity to save lives. So we're really excited about the opportunity to do this. Gift of Life has saved the lives of people I care about, has probably saved the lives of people that you care about. So it's not very often that, as somebody who does tax policy, we get the opportunity to come in and work on legislation that's potentially life-saving. But we're really excited to have the opportunity to do that. I want to thank Gift of Life and Secretary of State and the other stakeholders that have worked with us, the bill sponsors. We're really pleased about this proposal and really excited to see it moving forward. So thank you, and we're happy to answer any questions you may have.
I'm going to take Chair's prerogative and just ask. I was told that there is a time component. This is time sensitive. If we wanted to accomplish it by next year, could you speak to that?
Sure. So, we're in tax year 23 right now, and so we'll start processing tax year 23 returns early next year. So we do want to get this done as quickly as possible, early summer, so that we can make the changes, because it's not, when you add something to the income tax return, it's not just the Michigan Department of Treasury, but it's all of the preparers that do that. It's H&R Block, it's the people who make tax software, and so we need to have the opportunity to get the information to them so they can include it as well going forward.
So early summer as in?
I mean, it would be
June?
great to have it done by June, yeah.
Okay, thank you. Any other questions? Rep. Brian Gins.
I had the same question as you, Chair, so thanks for asking.
Wonderful. Great minds think alike. Thank you so much for your testimony. We really appreciate it. All right, I'm going to read in cards of support for these bills first. So 4362, 4364, Blue Cross Blue Shield of Michigan, Michigan Health and Hospital Association, Michigan Department of Treasury, Michigan Department of State, Patricia Jo Herndon from Michigan Donor Family Council, and Trinity Health. And then I'm going to go back in time and read the cards that I should have read before for House Bill 4409. So we've got support from Keith Lake. And I did see on this card, I'm sorry that we missed the opportunity. If Keith is still here, did you want to make remarks? Keith Lake, if you're still here. Okay. From the American Health Insurance Plans, Michigan Nurses Association supports HB 4409 as well as 4362 through 4. McLaren Health Plan supports House Bill 4409 as well as HAP, as well as, there's a couple health and hospital associations. Make sure I got the, yep. Meridian Health Plans, Upper Peninsula Health Plan, and then Michigan Manufacturers Association opposes HB 4409. I already read them. And Gilead Sciences opposes 4409. Oh, and MishBio also opposes. Representative Farhat moves to excuse Representatives Neely and Whitsett, as well as Filler. There being no objection, the motion prevails by unanimous consent. Yes. There being no further business before the committee will stand adjourned.